Sure. Well, thank you for the organizers for inviting me, and thanks for your kind words, Jay. So, okay, let me just start. So this is a very interesting topic, reintervention and in-stent restenosis of branch pulmonary arteries. Now, I actually think this is an important topic because when we put a stent into a body, we have to think long-term, especially in a child. How are you going to keep up the size as the child grows? So reintervention is a very important topic. So let me just start. Okay, so when we talk about reintervention, there are two major activities. One is redilation, and when we say redilation, the implication is that there is an in-stent proliferation that requires us to repeat the dilation. That's what redilation means. That can be from in-stent intimal proliferation, it can be from a stent fracture. But on the other hand, we can also be thinking of further dilation. And I want to make that as a distinction because further dilation implies that we have to make the stent larger to accommodate somatic growth. It's not the same as restenosis and then need to redilate. So of course, other reinterventional activities would include maybe adding additional stents, and that could be because there's an adjacent stenosis that was missed, or it could have been developed over time. It could also be a de novo stenosis that evolved. We can also end up having to do a reintervention, especially with jail side branches. And of course, I like to touch upon what is the role of the surgeon when it comes to pulmonary artery stents when they take a patient to the OR for an unrelated operation. So this is an example of some of the causes of restenosis. This is in-stent restenosis. You can see clearly there. You can also have a stent fracture. Now, if you look at this, it doesn't look so bad, but this is an X-ray that happened over several years. And you notice that it slowly became fractured. Now, this is just the picture showing you can almost see the movement of that fractured stent and see the stenosis there. Now, this is somatic growth. Now, look at the stent. The stent was dilated to the size of the distal vessel. But a few years later, this is what it looks like. The stent is still the same diameter, but look how much the distal vessels have grown. So, of course, now the stent is the bottleneck, and you have to make that stent bigger to accommodate the growth. To me, this is further dilation, not redilation. So this in order to understand reinterventions, we should have to think long-term. What are some of the long-term data? So this is a paper that came out 2010, a long time ago, but it was an important paper looking at 15-year follow-up out of Texas children. So this is about 1989 to 92. 68 patients had stents. Now, some of these were lost to follow-up, but 50 patients, well, 71 stents were included in the study. They're looking at what's happened to that stent over time. And I'll go through this quickly. So there was adequate data for about 43 of these patients, looking at cath, echo, and clinical data. The initial age of the stent implant was 12.6. Now, that's kind of old in today's times, but back then, the stents were not put in little kids. They were put in little older patients. And so, of course, the follow-up duration was 13.3 years plus and minus 2.3 years. Now, at that time, the only stent that was available, the palm stent. So, of course, it's a moving target. We have newer and better stents now, but this is the data from back then. And basically showing that there are some procedural complications back then. This is the late follow-up data. There were 4 deaths due to the underlying congenital heart disease itself. One death happened as a result of the reintervention, and a stent had ruptured or created a communication to the RPA. This happened in a detransposition in a Lecomte maneuver, and we know that that's a possible complication when we further dilate these types of patients. So we should always have a covered stent available for this. Back then, we didn't have that. There were 4 late complications, 3 minor ones, and stent fractures. I showed you one of them, significant aneurysm in one of them after dilation. The follow-up cath data was on 36 patients and 55 patients. Again, the mean follow-up was about 7.2 years in this cohort. I'm just going to go through this quickly. Many of them actually require either a redilation or a stent. This is what the stent diameter is to start with, and the final diameter was 13.4. The pre-stenosis was 62%, and it decreased to 12%. And the final diameter that was used was 16 millimeters. Now, that's actually pretty close to adult size as far as the size of the native pulmonary arteries. So basically, it showed that the higher initial gradient was associated with a final diameter of less than 14. In other words, more severe is it's harder to get to adult size. And the younger the age was not a factor in terms of the need of the final outcome. So you look at this, that starting at 4.7 millimeters of diameter, it almost tripled the diameter in the follow-up. Well, what's important is that of the 43 patients, looking at the New York Heart Association functional class, 1 and 2 took up almost the entire cohort. I think it was 91%, with a few that had higher classifications. 7 of them needed additional surgery, conduits, including conduits, Fontaine revisions, and 1 was to attempt to repair that pulmonary artery to PA communication, which was the erosion that I mentioned earlier. So again, the majority of these patients actually had a very good functional classifications. So just keep going. There were some stent fractures, 3 out of 55 patients, or 55.5%. There was no fragmentation or embolization. The vessels remain patent. There was 1 death. This is the patient that died from the dilation from the communication that was created between the pulmonary arteries and aorta. And 5 of them did die during the follow-up period. 1 was from a TET, progressive RV dysfunction, another TET with atrial arrhythmias, and then there's a TGA that had progressive RB dysfunction, and then Fontaine failure as well. So there are going to be some deaths over the long term of these patients, but not all of them are related to the stent, but not to the natural history of the disease. Of course, the ones with the communications, the dissections, we have cover stents to help that now. So that, again, this is a little bit of a moving target. If you look at the procedural complications, there was, as I mentioned, the erosion from the further dilation in the transposition patient. There was 1 that had a dissection that led to a hemothorax, and then that was taken care of, and then the aneurysm was found at that follow-up cath, and then that aneurysm was coiled. There were several minor complications, like a small aneurysm, and then a spleen ruptured and had to retrieve a fragment and some arrhythmias. So that was the most important erosion. And again, as I said, this has been reported in cases already, especially in transposition and the LeCompte maneuver. We have to be careful with those. Let's talk about jail stents. Now, of that group, about 27 out of 55 had a jail upper lobe branch. A third of them had preserved flow. About half of them actually had diminished flow at that time, and there was no flow in 5. So we lost flow in that. Again, as I said, it's mostly the upper lobe in the proximal branches. So 18 patients did have diminished flow or no flow, but the RV pressure was better. Basically, what that meant was that the upper lobe was sacrificed, but improved flow to the lower lobes that actually overall was still to lower the pressures. The overall, the pressures dropped from 86 to 60 millimeters of mercury over a 6.5-year follow-up. But of course, now we have open cell stents that we can go through the side and open up some of the side branches. So that, of course, these have led to less problems with jail side branches nowadays. So here's an example of the Max LD stent and a Vallejo stent. You can put a balloon through the side and create a new side hole for the side branches. The conclusion of that paper was that stents in pulmonary stenosis can provide effective improvement of the vessel caliber in the long term. And although repeat interventions are necessary, the procedure does reduce RV pressure and provide an alternative to surgery for residual pulmonary obstruction. Now, I did a little bit of a literature search for a debate in the past, and if you look at the paper that we pulled out of 58-page series, if you look at overall, the gradients in this cohort of papers show that the gradient dropped from 42 to 14, the diameter doubled at 4.36 to 9.21, and the RV to FA ratio dropped from about 2/3 to less than a half. So again, this shows that these stents can really help the clinical picture of the branch pulmonary stenosis. So we know that stenting is quite safe. Here's a good example of a 10-year follow-up of a Fontaine that had almost a loss of all flow to the left, and once you open that up, you can actually improve that flow. Here's another one. The same patient now basically gone up to from 0 flow to 13 millimeters over a 10-year follow-up. And then there's another 14-year follow-up looking at the initial diameter of 4.5. Then you can see there's a gel stent, a gel upper lobe there, went to 10 millimeters, 13 millimeters, and then eventually to 12.7. Again, pretty much similar, but over a 14-year period, the vessel has continued to maintain its patency, and with further dilation, maintain the larger diameters. Another 4.9 year had unifocalized vessels. You can see these are very tiny vessels, and then bilateral stents were placed, and then eventually got up to 13.5 millimeters on the right, 12.7 on the left. And you can see that you can continue to further dilate them to get them to normal, close to normal size. The stent fracture, we know that that's another cause for the need for restenosis. So we actually looked at this when I was at Texas Children. Again, another old paper looking at all the patients that had the pulmonary artery stents between 1990 and 2006, of which there were 265 patients. Out of that, the 395 patients had a stent in a branch pulmonary artery, so about 2/3 of these. There were 14 fractures out of this group, giving about a 2.4% fracture rate at 5 years follow-up. There are 4 on the right and 6 on the left, and a few in the conduits. So basically, we can see them more in the lateral fluoroscopy as opposed to the AP. And it's interesting that if you were just to look at x-rays, only 71% can be identified. The other 30%, you cannot tell that fracture. That's because you can't see movement on the x-ray. So if you really are concerned, take the patient to the cath lab to look at fluoroscopy, and you'll see movements if on the stent if it was fractured. So among the fracture stents, basically 5 were redilated, and then additional stents were placed in 3 of these. I'm not going to talk about the conduits right now. And then basically all the fractures were asymptomatic. And so the conclusion is that while the RB2PA conduit stents can fracture more frequently, it is relatively rare in pulmonary arteries, about 2.5%. Most of these are does not embolize, and therefore remain patent. So here's another example of a fracture stent, and you can see that on the lateral projection as well. So if you compare another paper from Dolph McElhenney, he had reported 21% fracture, and then from our center with Dr. Breinholt, it was a 2.75% fractures. Again, it's pretty low in our hands. There's an example of a fracture there, and you can see that we can put a second stent in, telescope it, and then round it all out so that we can get rid of the stenosis and eliminate that obstruction with an additional stent. So what about infancy? Because nowadays we put stents in more and more in smaller kids. What is the data there? So this is a paper that was presented a few years back looking at stenting in pediatric patients less than 12 kilograms. Again, I'll just highlight to you that this, in overall, the age of this group was 1.2 years, weighing about 8 kilos. And if you look at the results, the diameter increased from 3.2 to 7.2, so more than doubled. The initial gradient went from 33 to 9, and then the RV to FA ratio went from 3/4 to about half. So again, these represent some of the more severe patients in this age group. If you look at the results in follow-up, over 10 years now, and the mean age at this point is about 11.6 years, and many of them did have require reintervention, including angioplasty and additional stenting. I would submit that the angioplasty is mostly due to somatic growth, and I'll show you that data later. Again, you see that the mean time between the interventions is about 5 years, but if you look at it between the initial implant and the first intervention, it was about 1.9 years. And then between the first and the second, it now increased to 5 years, and between the second and third, 7 years. So you can see that as you get further out, the need for intervention increases in duration. So again, I want to just point out to you some of the indications here for residual waste or initial limited dilation. It was about 25% of this patient. Somatic growth was another 22%. 18% represented adjacent stenosis, and then a smaller amount, 11%, was due to intimal proliferation. So again, that tells us, that gives us the gamut of what are some of the reasons why reintervention is required. Of course, there are some complications, and there were 5 deaths, and 1 was transplanted. The reintervention complications actually was balloon rupture in 3 of these, a pseudoaneurysm that then was treated with a covered stent. There was an LPA to aortic fistula, again in the transposition patient with a LeComp that was treated in a covered stent in 2 patients, stent fractures in 2. And then, of course, there were some surgical removals because those patients also required additional surgeries. So that at the OR, the surgeons removed them or augment them in some manner. And I'm going to talk about that at the end. And then the majority of these patients on the New York Heart Association was classified in 1 and 2. So again, they were all doing pretty well for this group of patients. If you look at the diameters in general, the group started at 3.2 millimeters in diameter and over time increased to 10.6. Again, this represents the infant group, not the previous one where the patients were stented much earlier, much later in life. If you look at the PA gradients, it decreased from 33 to 11 over time, and the RV to FA ratio went from about 2/3 again, 3/4 to about a little over 50%. So these are the data from infant stent follow-up over time. Here's an example of a 4.8 month old, 6 kilogram, who had a TET repair. You see how hypoplastic the LPA is, 2 millimeters in diameter. We put the stent in, increased it to 5.5, then a follow-up in 6 months, 6.8 millimeters. And you can see how the distal vessels are growing because now you're getting better flow through the LPA here. 3-year follow-up and then 7-year follow-up. It's gone from 2 millimeters to 11 millimeters. And again, you see how nicely the distal vessel grew because you are able to increase flow to that vessel. Another patient over a 10-year period, 17 months old, you see this bilateral stenosis, putting stents in at 3 years follow-up, and then 10 years follow-up, again, went from 4.3 millimeters on the right to 13.7, and then 4.1 on the left to 13.9. Again, showing that these stents can be further dilated. It needs to be further dilated to accommodate the growth of the child. But you can do this effectively. This is another 12-year follow-up. You see the stenosis here. And then 2 years later, we make it bigger. And then 12 years later, now it's 14. What's interesting to me is that if you look at the distal vessel there, that vessel is increasing size. So definitely you can make this close to adult size on these types of situations using the correct stent. So the conclusion was that the intravascular stents can be safely delivered in small patients, smaller than 12 kilograms. Serial stent expansion can maintain good hemodynamics and anatomy all the way through adolescence and even adulthood. And then what about the distal growth? I sort of alluded to that. This is a paper that I did with one of my former fellows in LA, looking at growth of the distal PAs after you stent them, again, in mostly small patients. And I'm going to go through this quickly. If you look at the 2 ventricle patients, this is the normal branch. That's the side that did not need a stent. And you see that once you put the stent in, there's catch-up growth of the small vessels so that they actually catch up to the other side. If you look at the upper lobe, again, the unstented size grew 21%, but the stented side went up 44%. So that means that there's a lot of catch-up growth there. Again, the lower lobes, they didn't change that much. The unstented side grew 14% in the follow-up, while the stented side only went up 19%. So again, same thing. If you look at the single ventricle patients as well, the changes in the size between the normal side and then the stented side, there's a lot of catch-up growth there. In the upper lobe, the same thing, 53%, 29%. Now, that didn't make a lot of sense, but this, again, it's in a single ventricle. So I think the impact may not be as good without a pumping chamber. Again, the lower lobe are very similar, 23% to 22%, comparing the normal side versus the stented side. So basically, we learned that the lower weight at the time of stent implantation is associated with better growth. The p-value was 0.05. The younger the age and the lower the body surface area, you tend to have better improved flow towards the growth, especially to the lower branch, and it was reaching near significance. The key thing was that the areas that were stented that improved flow, there was good catch-up growth so that it matched the other side. As a 20-month-old, you see again how tight that vessel is, 3.8 millimeters, put up to 8 millimeters. Again, you can see the smaller branches have much better perfusion 5 years later. And then you see how even at that point, the stent is now becoming the bottleneck because the distal vessel has grown very nicely. You have to keep following the further dilation to keep up the growth. See how nicely the distal branch is. So the conclusion is that stent can effectively relieve and then promote lobar growth in both single and two ventricle patients. The greater the growth can be seen in the two ventricle compared to the single ventricle. And maybe it's because there's a pumping chamber there. Early and aggressive stenting is beneficial to promote branch pulmonary artery stenosis. Some of the long-term follow-up of this is that the outcomes are excellent. And so far, it suggests that the stents can be blown up to, that can be further dilated to accommodate growth, even up to about 16 years. So by then, you're a adolescent near adult size. The data for the long-term follow-up is still quite scant, and fracture is still very uncommon even in the infants, but it can be further dilated or restented successfully. Low complication rates. There's good catch-up growth of the distal vessel if you stent it early enough. And overall, we think that the aggressive stenting in infants can be very beneficial to lung growth. This is the last part of this, and I'm sorry I'm running a little late. We actually looked at surgical manipulation of stents and how does that impact the need for reintervention. I thought this was quite interesting to share. So we looked at patients who had a stent and then went to surgery, and then the different things that the surgeons did and how that might impact reintervention. 54 patients, 70 stents, and you see that 18 in the right, 20 in the left, and about 16 that were bilateral. And of course, so for some of the smaller kids, the patients went for primary cardiac surgery. After the stenting initially, some of them were for a conduit changeout, some were for Fontan revisions, and then primary TET repairs and one resection. So if you look at the stent, either they were not touched in the time of surgery when the unrelated surgery was done, or what happens is that they could remove that stent at the time of surgery, or they trim it, or they fillet it open and put a patch in. And what was really interesting, that if you look at this, if you look at the cohort of untouched patients versus those where the surgeons actually manipulate stent, the overall patient profile is pretty similar on both sides. But if you look at what happens to the stent and when intervention was needed, the side that needed to have further intervention on the side that the surgeon did not touch the stent was 29%. Compared to 26%. So again, very similar. But if you look at what kind of surgical manipulation took place, the group that had a stent totally removed, the reintervention rate was 10%. If the surgeon trimmed it, the intervention rate was 29%. If they cut it and put a patch on it, the reintervention was 60%, much different from the other types of it. So basically, it showed that if you look at the age of the stent and the age when the surgery is, that actually impacted the timing for reintervention. However, if you actually look at the different types of surgical manipulation, the one where they the most important thing that needed reintervention was the earlier significant gradient was what determined the need for further intervention. If you look at the different types of surgical manipulation, this is the group that did not have the stent touched, and then so therefore that's what the freedom for reintervention is. The stents that were removed was the green line here. If you go to the one where things were trimmed, this was the reintervention rate. And then if you go to the one where it was cut suddenly, this was significant. Again, pointing out that if you actually fillet the stent longitudinally and put a patch in, the risk of reintervention is a lot higher. So therefore, this is an example of one where the surgeon at the time of surgery of the pulmonary valve decided to remove the stent, to cut it longitudinally and then put a patch in. Look what happened to it afterwards. It actually was worse by doing that. Here's an example where the surgeon actually had fixed the stent was cut it out. Sorry, I can't read the top of my thing here. I'm just going to move it over a second here. And anyways, this is one where they trimmed it back, and you can see that there is some restenosis there where the stent was manipulated, and here's a part where the stent was trimmed back to accommodate the conduit, and that was what it looked like afterwards. That looked pretty good. So let me just conclude that there were no difference in the rate of reintervention when the pulmonary artery stents were untouched or whether the surgeons had manipulated. But if you transect the stent and patch it, that actually shortens the time to reintervention. So therefore, the caution is probably leave those stents alone rather than try to patch it up. The preoperative residual gradient is a good predictor of the need for reintervention after surgery. And let me just summarize everything. Reintervention needed for a variety of reasons, including in-stent restenosis, development of adjacent stenosis, jail side branches, as well as after surgical manipulation of stents, and rarely stent fracture. The further dilation is needed to accommodate somatic growth. Pulmonary artery stents can be further dilated to adult size even from infancy, providing long-term patency, reduces RV pressure load, and improved clinical status. Repeat interventions, including angioplasty and additional stenting, can be performed safely and effectively. Early aggressive rehabilitation of the branch pulmonary stenosis during infancy can improve distal growth of the pulmonary arterial tree. And finally, surgical manipulation of pulmonary stent does not improve, but may actually increase risk for need of reintervention. Thank you for your attention.